Hello and welcome back to Clinical Cases. Today we're going to be looking at the next 10 cases that we were taught about in the gastrointestinal system. So these will include appendicitis, and we will also look at inflammatory bowel disease, so Crohn's and ulcerative colitis. We're going to look at the impact that surgery and drugs have on the GI tract. We're going to have a look at viral and bacterial gastroenteritis, have a look at cancers and some pre-malignancies which cause cancer in the long term, colorectal cancer and defecation as a process. So first of all, let's have a look at appendicitis. So appendicitis, again, as we previously discussed in the last video, you've got itis at the end, which refers to inflammation. So this is inflammation of the appendix, which is a 3.5 inch long tube of tissue that extends down from the large intestine on that right hand side. In terms of symptoms, it causes lower abdominal pain, nausea, which can be with or without vomiting, a decreased appetite. But what's problematic in appendicitis is 40% of people don't have these typical symptoms. So a common problem that a lot of people know about is an appendix rupturing. So if this happens, it can cause widespread painful inflammation of the inner lining of the abdominal wall. And one complication that we're really concerned about if the appendix does rupture is sepsis, because obviously this can have long-term implications, particularly on the recovery time. If we do diagnose appendicitis from signs and symptoms, physical examination so we can assess for pain, we can do blood tests, urine tests, etc. The best way to treat appendicitis is an appendectomy, so a removal of the appendix. And if the appendix has burst and an abscess has formed around it, we need to drain the abscess first, then wait for a few weeks and then perform the appendectomy to remove the appendix when that infection is under control. It can take weeks to recover from appendicitis because obviously you'll require surgery to remove it, and it can take even longer than that if it has burst and the abscess forms and so on. It takes a much longer time to recover. Next, to look at inflammatory bowel disease. So there are two types of inflammatory bowel disease to be aware of: Crohn's disease, which we're going to talk about first, and then ulcerative colitis, which we'll look at second. So Crohn's disease, what's particular about Crohn's disease, differentiating it from ulcerative colitis, is that Crohn's disease can affect any part of the GI tract from the mouth to the anus, and it usually affects the ileocecal region. At least 115,000 people have been diagnosed in the UK, and it's technically not an autoimmune disease. It's just said to be immune related. However, ulcerative colitis is classed as an autoimmune disease. So there are two key differences between them. So Crohn's is can affect any part of the GI tract from the mouth to the anus, and it is not necessarily an autoimmune disease, it's just immune related. So symptoms: people with Crohn's disease can experience periods of severe symptoms followed by periods of remission. So periods where symptoms are really bad, so with chronic diarrhea, which can be bloody, containing mucus or pus, weight loss, fever, abdo pain, tenderness. They have periods where these symptoms are heightened, and then times where they don't have any of the symptoms at all. So the precise cause of Crohn's disease is unknown, but it's likely to be an abnormal response by the immune system, as we've already said, which is triggered by some kind of pathogen such as a mycobacterium paratuberculosis, pseudomonas, or listeria, or so on. It can also be genetic, so it can be inherited, but also environmental factors are believed to play an important role. So if you are of Jewish European descent, you have a greater risk of being affected by Crohn's disease. If you're young, so most people are diagnosed with Crohn's by the age of 30, and smoking also increases your risk of developing Crohn's disease. Moving on, we have ulcerative colitis. So this again is another type of inflammatory bowel disease, and it results in inflammation and ulcers, particularly of the colon and rectum. So remember how we said that Crohn's is all about anywhere from the mouth to the anus. Ulcerative colitis is very specific to the colon and rectum, and usually it's very localized to this right hand side, this right descending colon and the rectum. It's a continuous inflammation, and we've said it's localized, and it is an autoimmune condition. So the symptoms we consider as weight loss, diarrhea, possibly with blood, abdo pain, fever and anemia. And again, we've discussed previously how they can have flare-ups and remissions, so periods where the symptoms are heightened, where new damage has occurred to the lining of the colon, and then periods of remission, where the tissue is healing, and therefore there are a few symptoms associated with this time. So environmental factors can play a role in ulcerative colitis with regards to stress and diet, but largely it's down to this autoimmune condition where the T cells are destroying the lining of the large intestine and leaving behind some form of ulceration. which is causing the symptoms. So this can be diagnosed with a blood test, so we can look for signs of anemia or signs of infection. We can do a stool sample, or we can do a colonoscopy where we can take a biopsy, which is probably the most common way of diagnosing ulcerative colitis. We can treat it with corticosteroids, so anti-inflammatory medication. We can treat it with immune system suppressors as well, and also surgery, but this involves removing the whole of the colon and rectum. So actually that's a very, it has a large impact on the patient's life if you do go ahead with that treatment. Moving on, we can look at surgical procedures causing GI disease. So bariatric surgery is probably something that a lot of people are very familiar with in terms of they're aware of it. So it's a procedure with the aim of inducing weight loss. There are 3 different types of bariatric surgery. So you can have a restrictive surgery where you have a gastric band fitted, and this is probably the most common. You can have a restrictive and malabsorptive form of bariatric surgery where you have a Roux-en-Y system, and then you can have the malabsorptive only type where you have a sleeve gastrectomy. But consequently, it does restrict the intake that you can have, so you have reduced fluid and reduced fibre intake. It can cause reflux, vomiting and dysphagia and dysmotility, so therefore we have a reduced gastric capacity. So largely these are, in the long term, causing the symptoms that the patient wants. They want to lose weight, it induces that weight loss, but also it can cause issues in terms of nutritional and vitamin deficiencies, so B12, calcium, folate, they're not being absorbed as they should. And following bariatric surgery, you can suffer from something called dumping syndrome. A right hemicolectomy is a removal of the part of the colon which attaches to the small intestine up to the remaining colon. So you remove part of the colon and then you attach the small intestine, so the ileum, up to the remaining colon that's left. So a right hemicolectomy removes the ascending colon and a portion of the transverse colon, and then attaches the small intestine to the remainder of the transverse and descending colon. It's necessary to remove this much due to the blood supply, so obviously you probably don't need this much removed in terms of the reason for the procedure. However, because of the blood supply to the colon, you do need to remove a larger proportion than what's necessary with regards to the disease. So consequently, the impact on gut function is that an ileocecal resection, it can cause limited absorption of sodium against that electrochemical gradient, and a terminal ileum resection causes a permanent reduction in vitamin B12 absorption. So it does again come back to nutrition really, in the effects on the gut. A partial gastrectomy then, so this is a removal of part of the stomach, and you can do this in 2 ways to rejoin the remainder of the bowel to the remainder of the stomach. So you can join the bowel to the new end of the stomach, so if you're taking away that end pylorus part, you can join the bowel to the new end of the stomach, so this is a Billroth 1 technique. Alternatively, you can stitch the bowel onto the side of the stomach. This is a Billroth 2 technique, and there are 2 images at the bottom here which demonstrate this. So this is where the small intestine has been stitched onto the end of the stomach, and this is where your small intestine has been stitched onto the side of the stomach, so you can see the end of the stomach and the end of that small intestine has been almost closed and stitched up, and then this part of the small intestine has then been attached to the middle of the stomach, essentially the side of the stomach. So consequently, this can cause diarrhea. This is probably the most common GI malformation of this surgery. It can also cause dumping syndrome in early and late stages, due to the fact they've lost the pylorus. It can also cause a bacterial overgrowth. It can cause rapid gut transit. It can cause bile acid malabsorption, because remember you're skipping out this first part of the duodenum, essentially, particularly in this Billroth 2 technique. It can cause pancreatic exocrine dysfunction for the same reason, and it can cause gastroparesis as well. So next, very quickly be aware of drugs that can consequently cause GI disease. So we can have drug-related diarrhea, and this can occur due to 4 different mechanisms. So this could be osmotic, secretory, inflammatory or motile. Peptic ulcer disease can occur due to drugs, so this is a break in the lining of the mucosa with an appreciable depth, which involves the stomach or duodenum. So complicating wise, this can cause bleeding and perforation. So there are several ways that this could happen. So H. pylori infection is a massive cause of peptic ulcers. So are NSAIDs and aspirin. So NSAIDs and aspirin are obviously related to these drugs that cause GI disease. And then we can have microscopic colitis, which is a syndrome of watery diarrhea with normal colonic appearances and histological changes of inflammation, with or without thickening, essentially, of the subepithelial and collagen table. So these are associated again with NSAIDs, so NSAIDs seem to be the problematic drug associated here, but also SSRIs, beta blockers, statins and PPIs can all contribute to microscopic colitis. Next we've got viral and bacterial gastroenteritis. So gastroenteritis is inflammation of the lining of the stomach, and viral obviously it refers to the cause, which is viral. So viral gastroenteritis causes millions of cases of diarrhea each year. And anyone can get it, and most people recover without any complications. However, if complications do ensue, it can cause dehydration. That's probably the most common complication, and when someone doesn't drink enough fluids to replace those that are being lost through the diarrhea, and therefore obviously dehydration ensues. Rotavirus is probably the most common viral cause, particularly in infants and young children. Norovirus affects people of all ages, but is more common in adults. You can also have adenovirus and astrovirus, which also contribute to the causes of viral gastroenteritis. Usually it's diagnosed through symptoms alone, but a stool sample can be used to check for viral presence. Next we've got bacterial gastroenteritis. So again, gastroenteritis is exactly the same. We've got inflammation of the lining of the stomach, but bacterial, again, this refers to the cause. So bacterial gastroenteritis can be caused by a variety of bacteria such as Campylobacter, E. coli, Salmonella, Shigella, Staphylococcus, and Yersinia. Symptoms are very similar, so it can cause loss of appetite, nausea, vomiting, diarrhea, abdo pain and cramps, potentially blood in the stool with bacterial. So prevention, it can be prevented by washing your hands and keeping the environment clean and disinfected. Please be aware of the two types of diarrhea. So you can have inflammatory diarrhea here and non-inflammatory diarrhea, and just go through the steps. They're fairly simple, step by step, and it's the impact that they have upon the microvilli and the enterocytes, the cells that the bacteria act upon. So just be aware of the characteristic differences between inflammatory and non-inflammatory diarrhea. And there's a little summary here of the different bacteria at the bottom, just whether they're gram-positive, negative, and how they infect the individual person. So next, it's important to be aware of the histology of GI cancer. So we will cover each GI cancer individually through these videos. However, to be aware of the histology, so you can have an adenocarcinoma, so most commonly in the stomach, because it's lined by that glandular epithelium normally. And there are two types of adenocarcinoma, so intestinal and diffuse type. So squamous cell carcinomas here, so you can see the squamous cell carcinoma here, and here. So esophageal cancers are most commonly adenocarcinoma, however now becoming more commonly squamous cell carcinoma in the Western world. Neuroendocrine tumours, these are fairly uncommon, but the histology here shows a salt and pepper nuclear chromatin arrangement. And then you can have GI stromal tumours as well, so these arise from the mesenchymal cells, which are those non-epithelial tumours, and 60% of these occur in the stomach and 35% in the small intestine. So microscopically they're well circumcised tumours, and microscopically they compose of spindle and or epithelioid cells. Pre-malignancies, so one to be really aware of is Barrett's esophagus. So this is a condition where the cells of the esophagus grow abnormally. So it's not cancer, but it can develop to cancer in a small number of people. Barrett's esophagus is mainly caused by acidic reflux, so that's gastroesophageal reflux disorder in around 10% of people. So adenoma, an adenoma essentially is a polyp, a benign tumour in the colon. And these are thought to give rise to cancer in the adenoma-carcinoma sequence, which we'll cover in a later video. So now to be aware of colorectal cancer, so this follows on quite nicely from that adenoma-carcinoma sequence. So colorectal cancer is any cancer that starts within colon or rectum, and they tend to be grouped together because they've got many features in common. And adenocarcinoma is by far the most common type of colorectal cancer, and it starts within those gland cells in the lining of the bowel wall, and the ones that normally produce mucus. And squamous cell tumours and carcinoid tumours are quite rare. Normally it can be environmentally caused, essentially colorectal cancer. However, it can be linked to genetics in two very specific cases. So HMPCC, which is also called Lynch syndrome, and familial adenomatosis polyposis. And these two tend to affect younger generations in the cause of colorectal cancer. So it's these polyps, particularly in these genetic causes, which then precede the cancer. Defecation is the last thing to cover in this video, just very quickly. So fecal incontinence is where you have recurrent uncontrolled passage of fecal material for at least a month. Constipation is where those bowel movements are infrequent and hard to pass, and this can often cause abdo pain and bloating. Obstructed defecation is where there's a difficulty in evacuating or emptying the entire rectum, and it can result in frequent visits to the toilet and even passing of soft motions. We tend to investigate these with an endoanal ultrasound or a defecating proctogram. That's everything for this video. As always, if you do have any feedback, please do let me know. Thank you for listening. I hope you found it useful.